opportunity to introduce Dr. Lauren McDonald, and I am a former patient of Dr. McDonald. She has been a nephrologist with Dallas Nephrology for over 30 years, and I am the peer outreach coordinator for Renal Support Network. I had my transplant 26 years ago, and so I met Dr. McDonald 27 years ago. And she was just so great, caring, and not to date either of us. By the way, you look as beautiful as you did back then, Dr. McDonald. She, whenever we talked about my type of treatment, my dialysis treatment, she gave me her recommendation, but she sent me home with two videotapes. So, like a VCR tape to date, how long ago that was. And I did actually end up choosing PD, which was what she recommended, but she gave me a choice. And so, with that said, she's a fabulous doctor, and she is here today to share about diabetes and kidney disease. Dr. McDonald, would you like to go ahead and share your information with us today? And
Sure.
Suzette, you're going to share her slides,
Is
right?
someone there working the slide?
Yeah.
Perfect. First of all, I wanted to say, Wendy, that was an excellent presentation. So many things were true. A lot of times I have patients come in just like yourself, and we have care everywhere, and it makes it so easy to kind of look and see what other doctors have obtained, what's in their notes. The other part of it now is we also get a feed with Epic from the pharmacy. So we know if people are filling their meds, all kinds of things. So that was an excellent presentation. I'm going to talk today about chronic kidney disease, specifically diabetes, but we're kind of going to overlap and weave and bob and everything. We're going to talk about symptoms, treatments, and also feelings. As was made by the previous speaker, when you have kidney disease or a transplant, it's not just you as the patient, it involves the entire family. Your whole, even your workforce, everybody's involved. So, as we all know, there's a lot of emotion that goes on. I also want to say when Wendy talked about self-advocacy, so important. It's important to get with a doctor that you're comfortable with. I always tell my patients doctors are like used cars, or used car salesperson. You just keep moving till you find the one that you like because we're all different. We're human. Well, anyway, I also want to say thank you to Cher and the Renal Support Network. Listening to the presentations, this has been outstanding. Next slide, please. Well, first of all, I just want to give a little premise on what do kidneys do. A lot of times we get patients in to see myself, the nephrologist. Why am I here? I make urine just fine. I go to the bathroom all the time. But you have to remember the kidneys do more than just produce urine. They help regulate the blood pressure. They manufacture something or synthesize something called erythropoietin, which goes to your bone marrow, causing your bone marrow to make red blood cells. Back in the day, as Cher mentioned, I was going to say I was in a toddler program, but when I was doing my fellowship at Parkland, UT Southwestern, we used to have to give patients blood transfusions. This was in the 80s. And that led to a whole nother series of complications. Now we don't have to give that many because of erythropoietin. You might hear the term Aranesp, Procrit, Mircera. Also, the kidneys help to control bones. Now, normally the body prefers calcium to be higher than phosphorus. And so what happens with kidney disease, you don't excrete phosphorus and it climbs in your blood. Remember, phosphorus is found in most dairy products, even some dark sodas. So when the phosphorus is high, the body does not like it. It sends signals to the parathyroid hormones in your neck, and the parathyroid hormone goes to the bone. It pulls out calcium to kind of bring that phosphorus down. They have a teeter-totter relationship. Those of us that are old enough remember what teeter-totters were. So as it pulls calcium out of the bone, what happens is the bones weaken. So that's very important. So the kidneys do a lot more than just make urine. Go ahead and next slide, please. Well, I'm going to come back to diabetes, but causes of kidney disease, just to review. I always like to make sure there is a journalist that I loved. His name was Joe Madison. He recently passed away, but he would always say, "Put it where the goats can get it." I like to make sure people understand. Sometimes as doctors, we talk in fancy language. I don't like to do that when I'm speaking to non-physicians because you got to understand your body. But causes of kidney disease in this country, high blood pressure, along with diabetes, some of the more common causes of kidney disease. There's genetic diseases, polycystic kidney disease. It's an autosomal dominant trait. There's heart disease, atherosclerotic hardening of the arteries. In addition to seeing this in areas of the neck, the brain, the heart, also the arteries to the kidneys can also become sclerotic from atherosclerosis. I want to mention non-steroidals, the Advil, Aleve, ibuprofen, BC powder, high doses of aspirin. Low doses are okay, but all of these can be a problem. I have dialyzed more than one teenage girl because the parents were giving them large doses of these non-steroidals for their menstrual periods and having cramping. So back in the 80s, when I was in medical school, these drugs were prescription. Now they're over the counter. So every drug has its positives and negatives, but if you have kidney disease, you don't want to take non-steroidals. Acetaminophen or Tylenol is best. There's other causes, primary kidney disease, which we call a glomerulonephritis, and there's hundreds of causes of that. There's also autoimmune disorders. We heard Wendy Rogers talk about lupus, but rheumatoid arthritis and others. Now, back up to diabetes. Diabetes is just a terrible illness in this country. Unfortunately, diabetes causes a vascular change in the lining of the blood vessel, the endothelium. The high blood sugars over time cause changes. And so you can get hardening of the arteries in the brain. You can have what we call microvascular disease in the heart or small vessel disease. Typically, when people have heart disease, you hear they've had bypass surgery. It's because they can eliminate a large lesion in some of the larger blood vessels in the heart, or they can put a stent in there, which is like a conduit. Unfortunately, a lot of diabetics have small vessel disease, and you can't really do anything surgically for that. We know that it causes changes in the blood vessels of the eyes, leading to blindness, causes problems in the kidneys, leading to kidney failure, also in the small blood vessels in the fingers and toes, leading to amputations. It's a horrible illness. If I had the opportunity to ask the genie in the bottle, give me one wish, it would be to do away with diabetes because it's just a real problem for the patients and trickles down to all of us, really, in the types of complications that it causes. Next slide, please. It's always important with any kind of kidney disease to know your numbers, know your blood pressure, know your blood sugar if you're diabetic, know your hemoglobin A1C. Now, we as kidney doctors look at something called the creatinine. Creatinine is proportional to your muscle mass. So most ladies, a creatinine of 1.0 or less is normal, men 1.2. I'm in Dallas. I have a lady that was a professional WNBA player. She's like 6'3", 200 pounds. Her creatinine is 1.3. She's got normal renal function. It's proportional to your muscle mass. We see, you can think of a Micah Parsons, Dallas Cowboy guy, big muscular man. His creatinine is higher than normal, but he has normal renal function. You also need to know how much protein you have in your urine. For instance, most of us make 150 milligrams or less of protein, albumin that is, in a 24-hour period. So if you're spilling excess protein in your urine, that's important. That's probably because of a kidney disease. When you look at your laboratories, and I'm so glad to hear that people are looking at the pieces of paper or to their MyChart, because I love it when patients come in with questions. If you see this estimated GFR, eGFR, bear in mind, ladies and gentlemen, it's an estimate. I don't put all my eggs in that basket, so to speak, or I take it with a big grain of salt. But that estimated GFR, glomerular filtration rate, tells me about your kidney function. But it's an estimate. There are more precise ways of finding that information too. Next slide, please. Now, I put this slide in here just probably in the last week or so. You may have heard on the news some new blood pressure guidelines this year that came out. On the right side of the screen, you see prevent equation. You're going to hear more and more about that. You can look it up on your smartphone. It uses actually your urinary albumin. So protein is important. Urinary protein is important, along with other factors in determining your cardiovascular risk. So you're going to hear more and more about this prevent equation, and it's very easy for anybody to put in their variables and get an answer. Now, normal blood pressure is 120 over 80. There's a stage called elevated, 120 to 129 over 80. You see stage 1 and stage 2. A lot of times I'll ask people, my patients, what's your blood pressure been like? They say it's normal. Well, normal for everybody is not what normal needs to be. So it's important to know what your blood pressure is. I've had people tell me my blood pressure was normal. What was it? 150 over 80. No, that puts you at risk for heart problems and all kinds of problems. On the other side of the slide, if you have elevated blood pressure or stage 1 or stage 2, most likely your doctor is going to tell you to make some lifestyle modifications. For instance, limiting your salt. You know, it's amazing. When you go to the grocery store, ladies and gentlemen, be a label reader. You've got to look at, because salt is in some diet sodas, it's in ketchup, it's in bread, it's everywhere. I usually tell my patients with well-controlled blood pressure, don't add any salt to your food. Now, this is the big change here that they were talking about. No alcohol, or if you do drink alcohol, for men, 2 drinks per day. For women, 1 drink per day. That affects some of us. Yours truly also. So that's something to bear in mind, because over time, excessive alcohol can contribute to hypertension. It's important to manage your stress. It's important to stay close to a healthy body weight. Exercise should be 150 minutes per week, and moderate exercise, and that's walking. Vigorous exercise, usually 60 minutes a week. It's important to check your blood pressure at home. We all know, you go to the doctor, sometimes you're running late, you're rushing, and really we should, according to guidelines, let someone sit about 20 minutes before we check their blood pressure. But you know that there's something called Press-Ganey scores. Like, you could ask, how was your doctor's visit? Well, when people perceive that they're waiting unnecessarily, our scores go down. So when people come in, you'll see the medical assistant kind of rush you to check that blood pressure, rush to put you in a room to wait for the doctor. That's not really ideal. I always like to ask my patients, you check it at home, what kind of numbers are you getting? Every now and then you might want to take your home blood pressure cuff and take it to the doctor with you to check what you get on your home device versus what they get. Also, the DASH diet really is something that we should all follow. It's using healthy fats, lean protein, whole grains, avoiding as much dairy or high-fat dairy. So all of these things are incorporated into these new guidelines. I just wanted to mention this because you may have seen it in the media. Next slide, please. Now, diagnosis of kidney disease, and that includes diabetic kidney disease also. We like to look at the labs, particularly the BUN and the creatinine. BUN stands for blood urea nitrogen. For instance, I'm in Dallas, it's about 98 degrees right now. If I was to go outside and mow the grass, come in, my urine would be dark, I'd be sweating, I'd drink water, all of that would change. If you checked my BUN at that time, normal is up to about 20. It might shoot up to 30 or 40. Once you rehydrate yourself, it comes down. Creatinine, as I said, is proportional to your muscle mass. So that's what we want to check. Also, potassium was mentioned earlier, but a high potassium, which we see with people with advanced kidney disease, also some diabetics with stage 3 kidney disease, stage 3 or 4, and I'll get into that later on. High potassium can make your heart stop beating. So it's important. Now, this is, I call the fruits of the summer garden. Looking at tomatoes, melons, those things are high in potassium, along with bananas, oranges, orange juice. These things are high in potassium. If you have advanced kidney disease, that can be a problem. Bicarbonate, you'll see on your laboratories. Bicarbonate is really acid. And you might see CO2, which is really carbon dioxide, but really the lab is measuring bicarbonate. Now, with kidney disease, kidneys excrete acid. When you have kidney disease, you tend to hang on to acid, making that bicarbonate go down. So we pay attention to that in the labs. When the bicarbonate is down, we say you have an acidosis. Sometimes we even have to treat that with a medicine called sodium bicarbonate, which really is Arm& Hammer baking soda. Sonogram, we like to look at the picture of your kidneys. As you can see there, we use sound waves, no needles. You just sit there. It's painless, fortunately. Now, people with normal sized kidneys, sometimes you see that with minor kidney disease, but sometimes diabetics can have normal sized kidneys and have pretty advanced kidney disease. That's because diabetics do something called hyperfiltration. So your kidney size might be normal, but your kidney function is not normal. There's also something that we use now called Natera. Now that's a brand name. It's a genetic test. It's very easy. They just swab your cheek and check your saliva. Now it really gained a lot of popularity, particularly for the prenatal screening of some ladies, and also for oncology, determining the best kind of treatments depending on your cancer. Now we use it more and more. For instance, if someone presents with kidney disease, we don't know why. It can kind of clue us in if there's some genetic issues, particularly if there's a familial kind of incidence. The other thing it's used for is transplant. Sometimes some primary kidney diseases are more predisposed to return if we transplant the patient. So we do use that genetic screening more and more. Next slide, please. And this is just a brief summary here talking about chronic kidney failure or acute kidney failure. As you can imagine, acute is something where the kidneys generally are normal size. It can be from an event, an injury, sometimes infection, we call sepsis, use of some medications, and the BUN and creatinine can become abnormal. Sometimes these people even need temporary dialysis, but they tend to return to their baseline. On the other side, chronic kidney disease, as I mentioned, diabetics can have normal sized kidneys. Now, when I talked about the creatinine with people having kidney disease, that creatinine climbs, and that tells us that toxins are not being cleared. For instance, we eat, our body metabolizes. What we don't need comes out in the stool or the urine. If our kidneys don't work well, those toxins build up in our body, and we call them, fancy language is uremic toxins. But these toxins or poisons lead to people having a poor appetite, therefore weight loss, nausea and vomiting, fatigue, or the fancy name you might see as malaise. Itching comes with advanced kidney disease from that elevated phosphorus. So people with advanced kidney disease, we use certain medicines to control the phosphorus, also making sure they see a dietitian to know what foods to avoid. Next slide, please. This is about stages of kidney disease. Stage 1 is normal kidney disease. Now, as we get older, there is some decrease in our kidneys, kidney function, particularly age 65 or older. You're going to see some normal decrease in the kidney function. You see the eGFR, that estimated glomerular filtration rate, 90 cc's per minute. That's kind of fancy language. That's how it's measured. When I explain this to my patients, I usually use a percentage that makes it easier to understand. So stage 1 or stage 2 are considered mild kidney disease. Stage 3, 30 to 59% is considered moderate. Stage 4 is severe. And in our practice, stage 4 is when we start education for chronic kidney disease, knowing that our patients could very well need dialysis and or transplantation in the future. Stage 5 is when your kidneys are working at 15% or less. We're usually preparing, as I mentioned, for dialysis or transplant at that time. Now I want to talk a little bit, I want to digress about diabetes on this slide, because sometimes you can have a pretty good clearance, meaning your eGFR is pretty good, but you're spilling more than 150 milligrams of protein per 24 hours. That could put you at stage 3 because you're spilling excess protein. When you're spilling excess protein, that tells us that there's damage to the kidneys. So about 15 to 20 years ago, if we sat here and you would say, Dr. McDonald, what can I do to prevent my diabetic kidneys from progressing to dialysis or transplant. I would say control your blood pressure. And going back to the 80s or 90s, 140 over 90 was considered good blood pressure control. As I said earlier, you've seen that those recommendations have changed. Like 120 over 80, they found if your blood pressure is there, you're less likely to develop cardiovascular complications. So I'd say control blood pressure. If you're diabetic, control your blood sugar. That A1C should be 6 or less. And I'd say exercise and maintain a healthy body weight. Well, you and I know that there's some people that can lose weight at the drop of a hat. You're like, my goodness. And there's those of us who have to work very hard. And there's people that do all of the right things and they still don't lose weight. I firmly think in the next 10 years or so, they'll be able to do a genetic study and say, McDonald, you do better with a higher protein diet. Cher, you do better with a ketogenic diet. I really think they'll be able to find what works best according to our individual metabolisms. But right now, I'd say stay as close as possible to your healthy body weight. Well, amazingly, and I'm sure you've heard of these medications. Back in the day when I was training at Parkland, UT Southwestern, we would use an ACE inhibitor, lisinopril, or an ARB drug, angiotensin receptor blocker drug like losartan, olmesartan, to control blood pressure, but they also found those medicines decreased protein in the urine. That's all we could do. Now, you've seen those, and I'm going to use the brand names because you've probably heard of Farxiga or Jardiance. And see the commercials, it's like High School Musical. But the wonderful thing with those drugs is that they help decrease protein in the urine. In some cases, they do help a little bit with blood sugar control. And then also what happens is they help prevent heart disease. And we found weight loss. There's another, and they're called serum glucose transport inhibitors. There's another category called GLP-1s, glucose limiting protein drugs. And you've heard of Ozempic, Mounjaro, Wegovy, Zepbound. I saw a man on Friday that lost 200 pounds on Mounjaro. Most of the patients I've seen on those drugs lose anywhere from 30 to 60 pounds. They've really revolutionized what we can do because these drugs, in addition to what I mentioned, decreasing protein in the urine means you're less likely to progress to end-stage disease. They're decreasing cardiovascular risk. And then in addition, this weight loss. Now, the other category is something you may not hear about as much, and that's a mineralocorticoid inhibitor called finerenone or Kerendia. Those drugs really have an impact with cardiovascular disease. Now, so it's wonderful to be able to tell my patients, you have diabetes, we're doing these things, you're obese, we're going to treat your obesity and indirectly help your diabetes, help your protein in your urine, indirectly help your lipids and your blood pressure also. So it's a wonderful thing. Going in the future, what you're going to see is a relationship between, we call it CKM, cardiovascular, kidney, and metabolic. Particularly in this country, so many of us are obese, and the obesity can start young. And then in addition to the obesity, these patients may develop diabetes. And then of course, here comes heart disease and kidney disease. So there's some clinics and university centers now that have a cardiovascular, kidney, metabolic clinic addressing all of those things. So these drugs have done wonderful things, especially for our diabetic patients and especially for our patients with obesity. In the past, people used to think of obesity as some kind of personal defect, and it's a disease. And I remember I was on a plane one time and a lady was obese and the flight attendant was so rude when she handed her the seatbelt extender. And I thought, this woman probably would never choose to be this size. Obviously, something is wrong. So I'm glad we're changing how we look at this as a disease process and not some kind of personal weakness. Next slide, please. Well, when we have diabetes and we're approaching end-stage disease, we look at dialysis or transplantation. Usually we start dialysis, I say anywhere from 2 to 10% function, but it's a clinical diagnosis. Sometimes patients that have heart disease or other problems start dialysis sooner than later. No one ever wants to do dialysis, but I'm amazed I'll have patients come in that have spent a lot of money on internet type stuff that tells them how to avoid dialysis. What I found is if you avoid dialysis and put it off, what happens is you have a poorer prognosis or greater morbidity, as we say in doctor language, and your increased risk of death does appear. So if your doctor is telling you that dialysis is in your future, of course, get another opinion, but take it very seriously. The longer you delay this, the more at risk you could be. Next slide, please. There's hemodialysis and peritoneal dialysis. Right now we have in-center, which is 3 times a week, generally 4 hours at a time, or home hemo at the same prescription, or sometimes more frequently, depending on what you and your doctor agree on. There's peritoneal dialysis, where we use the perineum as one big transport membrane. Next slide, please. Transplant, right now we like to focus on living donors. Remember, there's also paired donation. We do this by blood type. So let's say you need you need a kidney and you're type A. Your relative or friend is type O. And so what we will do is find someone that is the opposite. So there's a paired donation so you can still get transplanted. Next slide, please. Well, I just want to mention that African Americans, Native Americans, Hispanic Americans, and Asian Americans are more likely to develop end-stage renal disease. Some of it could be genetically based. Some of it may be to socioeconomic and disparities. Next slide, please. And these disparities that I mentioned have to do with income levels, health insurance, access to housing, medical care. You see the list there. But I just want to mention with some of the changes coming down the pike in health insurance in 2026, particularly with Medicaid, we're going to be in for some very rough waters. For some reason, people think that patients on Medicaid are just two-timing the system. The patients I see want to work if they can, but many times they're too sick to work a full-time job. So just letting you know that I think things were going to get much worse before they get better. There's just so many political things going on right now. Next slide. Well, I'm sure there's some questions. I kind of rushed through the end. I saw that time was waning. I'm happy to answer any questions that you have. Thank you.